Your Excellencies, esteemed guests, it's a pleasure to be here. My mother was born in Kisumu, on the shores of Lake Victoria. My father from Dar es Salaam. Two families who believed firmly in the concept of education will make a better life. And I see here before me a room filled with educators and leaders who are invested in the training of our African health workforce. So I stand here not as a visitor, but I'm at home. I'm with my people. And I have a question for you all today. Let's first think about a medical student in Africa today. She is 18 this month. She worked hard to get where she is. Her parents are so proud of her. She is brilliant. Now, let's fast forward 2040. She's 32, mid-career. What is that world that she is going to be practicing in? What will it look like? What knowledge will she need? What skills will she need to practice? So the question that should be keeping us all up at night, are we preparing her for that world of 2040? Let's think for a moment about what that world of 2040 will look like. It will look different from the world we trained in. It will look different even from the world of today. There are forces converging to create a fundamental shift in the life and the work of a health professional. One first force, we've of course heard that this morning, artificial intelligence. Today, AI systems can read an X-ray almost as good as an experienced radiologist. Within seconds, AI can summarize an entire medical record, can build a differential diagnosis, can alert us on drug-drug interactions in real time. Within the next decade, every clinical decision is going to have an underpinning of AI in it. So if machines can do the pattern recognition, if they can do data analysis, if they can build a differential, is there anything left for the human? Absolutely. It is the human connection come forefront. To speak to that frightened mother in her time of need, to make the decision in the middle of the night when the algorithm is saying one thing, but the patient in front of you is saying something different. When ethical reasoning is required to ration resources, the human connection will become more and more important in the world of AI. The second force, Africa is aging. Yes, we are still the youngest continent, but by 2040, half of the population over 60 will have nearly doubled. And that will make the disease profile in Africa so much more complex. Today, we already see we still have infectious diseases, TB, malaria, HIV. We have the unfinished agenda of maternal and child health, sexual and reproductive health. We have surging chronic diseases, diabetes, heart disease, cancer, depression. And on top of that, layered on top of that, we will have issues of an aging society, dementia, geriatrics, palliative care. These are things Africa's healthcare systems have only begun to grapple with. But in the life of our graduate in 2040, that will be her afternoon clinic. It may even be in one patient. It is not going to be a textbook, it will be daily life. Advancing science. Today, science is advancing faster than it ever has in history. We have precision medicine, regenerative medicine. We have immunotherapies. They are transforming what's possible, even in Africa, in prevention, treatment, curative. Today, gene therapies are advancing for treating sickle cell disease. We're using platforms for TB and malaria. We're seeing immunotherapies being used for cancers in Africa. Regenerative medicine will make it so that we may not need transplant infrastructure to deal with organ failure. And the opportunities for precision medicine in Africa are amazing. This continent has the greatest genetic diversity on Earth. Imagine the potential of tailoring treatments based on gene profiles. It will change the possibilities in Africa. But advancing sciences are only as good as the workforce that is prepared to use it. And climate change. Climate change is one of those forces that I feel in health professions education we may be the least ready to prepare to deal with. Changing disease vectors, escalating heat-related illnesses, migration, climate migration displacing communities. Unfortunately, these are not just projections for Africa. This is a reality for us today. And our workforce in 2040 is going to be needing to deal with it. Digital health, video conferencing, mobile health platforms, wearable devices. Our graduates in 2040 are not just going to be seeing patients in hospitals and in clinics. They will be seeing patients through a video. They will be supervising community health workers through a mobile platform. The clinic wall is dissolving. And decentralization, already here. We've heard about it today. Healthcare in Africa is already decentralized. We have already seen health task shifting and community-based health programs. But while care has moved to the community, our education platforms have not. Despite the fact that the majority of our graduates will practice in the district settings, the majority of our training continues to be in tertiary hospitals. We all know where our learners are practicing in their clinical years, and it's not where they're going to be practicing when they're in the workforce. So that world of 2040 will have a number of forces converging to create this fundamental shift. Well, let's go back to our graduate in 2040. Let's picture a day in the life, a Monday morning in 2040. She's 32, she's working at a district hospital, mid-career. She wakes up to her AI dashboard because her AI dashboard is tracking vital signs for patients in her community. The AI dashboard has flagged for her 3 patients. The first patient is a 68-year-old who has had HIV for 20 years. He's on antiretrovirals. He has heart failure. And the dashboard has flagged that he's having exacerbation of his heart failure symptoms because of an extended heat wave in his community. Unfortunately, this is more and more common in that community. The second patient who's been flagged is a 32-week pregnant woman whose blood pressures are increasing to dangerously high levels. And the third patient is a type 1 diabetic, a teenage boy with type 1 diabetes whose blood sugars have been erratic over the course of the last 2 weeks. Our graduate gets this data. Her role is to make a decision. She uses the data, but she also uses her knowledge of the community, of the context, of the patients to decide what needs to happen next. So she goes to work, and the first thing she does is she supervises and connects with her community health workers using a mobile platform. Through that platform, her community health workers share with her, connect her by video to patients, to 2 patients. One patient, she adjusts the medications, and she feels he's okay to stay in the community. The second patient is a 42-year-old lady who's had a chronic cough. They used a point-of-care diagnostic at the health post and confirmed that she has drug-resistant TB. Our graduate writes the treatment protocol, and she has just provided clinical care at a distance to a patient she has never met. She's used a point-of-care diagnostic that was not available at scale while she was training. She goes to clinic, she meets the diabetic, the teenage boy with diabetes. She pulls up on her tablet the pharmacogenomic guidance. She's able to make dose adjustments based on the genetic profile of that community that she knows is in that community. When she trained, it was one international set of guidelines. She moves from that patient to the 32-week-old pregnant lady. The AI has created within seconds a risk assessment of this lady, but she disagrees with that assessment because she knows something about that patient. So she adjusts the plan, and then she speaks in her language with the patient, with care and patience. She spends 20 minutes talking to that lady. And what's going to make the difference whether or not that patient comes back or is lost to care is the 20-minute conversation. AI took 3 seconds to prepare an assessment, but she spent 20 minutes with her patient. She goes from her clinic to the emergency room. There was a road traffic accident. 3 people injured. Short-staffed, short on theater, short in blood supply. No algorithm is going to help her decide when you have 3 patients and only 1 can be treated first. How do you make that decision? But she makes that decision with ease and care and confidence because she trained in a district hospital just like this. She's been there, done that, and she manages the situation. She goes home, she has dinner, she logs on to her continuing education platform where she does case-based simulation. It's a platform built by 4 medical schools across 4 countries. She's not learning because somebody requires it of her. She's learning because when she trained, learning is part of practice. So that's our graduate in 2040. Think about her day. She interacted with AI, precision medicine, point-of-care diagnostics. She treated at a distance. She navigated resources. She is technologically fluent, but she's not a technician. She is deeply, irreplaceably human. She is a lifelong learner, anchored in the African context. She works in teams. She is what we need in 2040. Are we on track to produce that graduate, that physician? I want to suggest that as we move forward to make that the standard, to produce that type of physician by 2040 as the standard and not as the exception, we need to make change at 3 levels. The first is at the level of our curricula. We need to be training for adaptive expertise, the ability to make decisions and reason when something is unfamiliar. We need to be training our students, teaching it, allowing opportunity to practice it, and allowing opportunities to assess it. We need lifelong learners. We can't teach them everything they need to know, but we need to teach them to think, to be able to understand new evidence, use new technologies. Our curricula need to prioritize those human skills: trust, judgment, empathy, the ability to talk to frightened families, the ability to make decisions in the middle of the night, to use that ethical reasoning. We need to be teaching it not as soft skills, as we often refer to it today, but as core clinical skills that our graduates are going to need. We need to teach it, we need to produce opportunities to practice through simulation, and we need to assess it just as seriously as we assess pharmacology. And last but not least, we need to teach digital and AI fluency. This is not about teaching physicians to code, but it's making sure that our physicians and our workforce understands AI and how AI comes to its conclusion so that they have the confidence to override AI and make the right decision for the context. It means our graduates need to be trained, our students need to be trained on using video conferencing platforms, telemedicine, understand how to interpret wearable devices, because that's the world they're going to work in. We need to teach it, offer opportunities to practice it, and then assess it. The second level of change will need to be at the institutional level. We, as the education programs, need to go to where the training and where the care is happening. We need to transform our district hospitals everywhere into thriving teaching hospitals, teaching spaces. We need to scale simulation, not as a replacement for clinical practice, but because simulation offers us the opportunity to practice adaptive expertise, to practice having human connection that matters. Simulation allows us the opportunity to practice, repeat, rehearse, and master and build that muscle of clinical reasoning that's going to be needed increasingly as our physicians graduate. And we need to invest in our faculty. And it's not a last but not least, because faculty are actually the priority. They are our engines. They run our programs. We need to invest in their ability to keep up with teaching methods, teach in new contexts, to be digitally fluent, to be fluent in the new advances in technologies. Investing in our technology is a must. If we don't do that, we can't achieve anything else. And at the systems level, we have to recognize that no single school, no single country can meet the moment of these forces. The scale of the forces, the scale of the change that we are going to see is monumental and will require a continental response. Imagine accreditation standards that allowed our graduates that where their credentials were recognized across countries so they can move to where the need is. Imagine harmonized curricula, where because diseases know no borders, right? The graduate in Lagos will face the same reality as a graduate in Addis Ababa. Yet today, we have hundreds of institutions creating responses to the same challenges. Imagine shared platforms. It's expensive to create digital technology, digital infrastructure, AI infrastructure, simulation infrastructure. But 10 schools doing it together will always outperform a single program doing it alone. And imagine all of this, Africa-led, Africa-governed, African innovation. That is the possibility of 2040. And as I conclude, I want to challenge the narrative of Africa catching up. That we're meeting gaps, we're meeting benchmarks that were set at a different time by a different people for a different context. When I look across the global community, what I see is institutions in wealthy countries that are struggling with legacy, 100-year-old curricula, tenure systems that are resistant to change, infrastructure that was built for another time. It's like they're renovating a building while there are 1,000 people living in it. But when I look here, out here, and look at what's happening in Africa, I see established institutions next to younger institutions, leaders who are not protecting the past, but who are planning and designing the future. I see momentum, new programs, new partnerships, new curricula, new campuses. I see leaders who are not renovating, they skipped that, they're designing for the future. So let's go back and think about my parents who prioritized education just like everyone here. But you have more than that. You have the power to change how generations of health professionals in Africa will be trained. And that gives you the power to influence the health of this continent over the next 50 years. That medical student, she's sitting in a classroom today, eager to be trained, to be able to work and serve in Africa. Her future is going to be influenced by these forces. Are we going to show up with a continental response? What we see here today, what should give us hope today, is the opportunity here today at MedEdAfrica 2026 to use every plenary session and every breakout session to come together to do what no one of us could do alone, to align, to share, to build a shared vision. So let this opening ceremony lecture be the starting line for a shared vision. I think we can, I think we must, and I think the people who can make this happen are in this room. Thank you.